স্ট্যাফাইলোকক্কাস সম্পর্কে কি আইডিয়া আছে একটু শুনি ফার্স্টে। এই যে বলো, লাস্ট বেঞ্চ, ওই জন্য বারণ করে লাস্ট বেঞ্চে বসতে। বলো, হোয়াট কাইন্ড অফ ব্যাকটেরিয়া ইজ স্ট্যাফাইলোকক্কাস? হ্যালো, আই এম স্পিকিং টু ইউ। গ্রে শার্ট উইথ spectacles, yes. স্ট্যাফাইলোকক্কাস কি গ্রাম পজিটিভ, গ্রাম নেগেটিভ, গ্রাম ভ্যারিয়েবল কি বস্তু? খায় না মাথায় দেয়? গ্রাম পজিটিভ কি ব্যাসিলাই? ব্যাসিলাই, ওকে। So he says Staphylococcus is gram positive bacilli. Pashajon, do you agree to it? Do you agree to it? Pashajon, do you agree to it? Staphylococcus is gram positive bacillus. Do you agree? Coccus. So he doesn't agree. Pashajon, sit. Staphylococcus is gram positive cocci in short chains. Do you agree? Staphylococcus এর মধ্যেই তো coccus রয়েছে। Then why are you saying bacillus? Sit. বসো বসো। কি হলো? কি? Do you agree to the Staphylococcus is arranged in short chains? No? Yes. Pashajon, do you agree to the statement? Huh? Short chains or pairs or clusters or tetrads? I give you 4 options. Pashajon, clusters. See, sit down. Staphylococcus is arranged in clusters. It's a GPC in clusters. Is it catalase positive or negative? Pashajon, positive. Name a bacteria which is catalase negative. Sit. Next. Name a bacteria which is catalase negative. That is also a gram positive cocci. No? Last bench. Green shirt. Yes. Name a coccus which is catalase negative. Staphylococcus is catalase positive, they have told. I am asking you, name a coccus which is catalase negative. Streptococcus. Sit down. Name one infection done by Staphylococcus aureus. একটা ইনফেকশন বলো যেটা স্ট্যাফ অরিয়াস করে। হ্যাঁ, শুনতে পাচ্ছি না, কি বলছে? Rheumatic heart failure, fever? No. Staphylococcus aureus doesn't do RHD. Why you have to go to so many difficult thing? Pashajon, very common infection. সবার হয়েছে পৃথিবীতে, এমন কেউ নিজে হয়নি। Tell me one infection of Staph aureus. একটা। হ্যাঁ, sepsis. Okay, brilliant answer. Sepsis is done by everybody. A specific infection bolo. Sepsis is like, everybody does sepsis. Huh? Skin infection, correct. So they cause abscess, staphylococcal abscess. Sit down. So more or less the last benches have answered. So you see, Staph aureus is an organism which is of varied importance, and they have a lot of things which they do. So we will see what they do. So Staphylococcus যদি জানতে হয়, then you have to know what is a gram positive cocci. Gram positive coccus is basic কি color হয় gram strain? Gram positive coccus violet. What about gram negative bacillus? Pink. Okay. So gram positive cocci, they are stained as purple in gram stain, and this is basically a coccus. That means it is spherical in shape, and based on the arrangement of a cocci, they can be classified into so many genuses. ঠিক আছে, gram negative bacilli এর arrangement নিয়ে we are not bothered. Okay, so whenever you see a report saying gram negative bacilli, you will not see gram negative bacilli in chains or gram negative bacilli in pairs. No, you will only see gram negative bacilli. That's it. But whenever you will see a gram positive cocci is written, there will be arrangement. If the arrangement is not written, call up the lab and tell the report is wrong or amend the report, because gram-positive cocci without arrangement is a wrong report. You have to write gram-positive cocci in chains, gram-positive cocci in cluster, gram-positive cocci in pairs. Okay. So here you see gram-positive cocci কে আমরা দুভাগে ভাগ করতে পারি, একটা হচ্ছে গ্রুপ ফ্যামিলি মাইক্রোকক্কেসি আর একটা ফ্যামিলি হচ্ছে স্ট্রেপ্টোকক্কেসি. The Micrococcaceae is basically consisting of the genus Micrococcus and Staphylococcus. Streptococcus এর মধ্যে রয়েছে Streptococcus, এবং Streptococcus is basically catalase negative and Micrococcus is catalase positive. Now whenever you see Micrococcus, তাহলে Micrococcus আর Staphylococcus এর মধ্যে ডিফারেন্স কি করে করব? Staphylococcus is generally arranged in clusters, grape like clusters, and Micrococcus is arranged in tetrads. Tetrads মানে চারটে চারটে করে করে থাকে Micrococcus সাধারণত, ঠিক আছে? সাইজটাও একটু বড় থাকে Micrococcus-এর Staphylococcus-এর থেকে. Micrococcus basically doesn't have a very much clinical importance because Micrococcus is basically a commensal of the skin. Now when I tell commensal of the skin, যখনই কোনো ব্যাকটেরিয়া commensal of the skin and we are immunocompetent individuals, তাহলে আমাদের কোনো প্রবলেম নেই. But whenever there is a immunocompromised status like HIV, like cancer, chemotherapy চলছে পেশেন্টের, সেখানে কিন্তু the commensal of the skin can give rise to a invasive infection. এটাকে মাথায় রাখতে হবে যে skin commensal যখনই বলবো, it doesn't give an infection to the normal individuals, but whenever there is immunocompromised status, they can give an infection. Now coming to Staphylococcus aureus. So in Staphylococcus we have two species, two broad species. One is Staphylococcus aureus and another one is categorized as Coagulase-Negative Staph. Staphylococcus aureus is Coagulase-Positive and Coagulase-Negative Staph যে গ্রুপটা আছে তার মধ্যে অনেকগুলো স্পিসিস আছে. কি কি আছে? We have Staph saprophyticus, Staph lugdunensis, Schliefferi, Hemolyticus, Warneri, etc. Okay. এর মধ্যে কিছু কিছু স্পিসিস they do cause an infection, ঠিক আছে, but most of them are again a commensal of the skin. So Coagulase-Negative Staph is a commensal of the skin. If I do a hand culture of you right now, I will find Coagulase-Negative Staph on your hand. তুমি তো হসপিটালে যাওনি, দেন কোথা থেকে এলো? It is a commensal of the skin. It is a normal commensal flora of our body. It doesn't produce any infection to us. But whenever there is a patient who has a central line, পেশেন্টটাকে সেন্ট্রাল লাইন দিয়েছি আর পেশেন্টটা নিজের সেন্ট্রাল লাইনটা ধরছে বারবার করে, তো ডেফিনেটলি দ্য commensal of the skin will be accessing the central line and that can give rise to a catheter or central line associated bloodstream infection, ঠিক আছে? So it is very difficult যে এই অর্গানিজমগুলো সাধারণত কোনো ডিজিজ করে না, but whenever there is a device inside the patient, they can give rise to an infection. Okay, keep that in mind. Now coming to the Staph aureus. Staph aureus, as I said, it's a highly pathogenic organism. It is a coagulase positive organism. মানে coagulase test যদি আমি করি তাহলে it will be coagulase positive, ঠিক আছে? আচ্ছা, so the staphyl means a bunch of grapes, coccus means berry shape. As I told that this bacteria is always arranged in clusters. They are never in chains, they are always arranged in clusters. So 1884 এ Staphylococcus aureus টাকে নাম দেওয়া হয়, and this aureus means what? This aureus means a golden yellow pigment that the bacteria produces. Aurum মানে কি? Aurum মানে হচ্ছে gold. From there it came aureus, ঠিক আছে? So aureus means a golden yellow pigmentation. So Staphylococcus aureus do have a pigment which is a golden yellow pigment, which is appreciated in which media? Media class তো সবার আগে হয়ে গেছে. Pigment production কোন মিডিয়াতে ভালো দেখা যায়? নিউট্রিয়েন্ট আগার. মিডিয়া বললে হবে না, নিউট্রিয়েন্ট ব্রথও হতে পারে, ঠিক আছে? ঠিক আছে. So nutrient agar is a simple media. nutrient agar, you can see the colony characters of a bacteria, including the pigment production. Okay. So this is basically what it does and what it has. Coagulase-positive, catalase-positive, facultative, anaerobe. Facultative মানে কি? Obligate and facultative, what is the difference? Obligate মানে সব সময়, facultative মানে হতেও পারে না। It can be anaerobe, it can be aerobe also. Okay, so facultative anaerobe means this basically survives in oxygen and sometimes without oxygen also. ঠিক আছে, তাই জন্য facultative anaerobe. This is non-motile and non-sporing, and occasionally they will have a capsule. Okay, as I said, golden yellow pigment on the nutrient agar, and there is something called beta hemolysis on the sheep blood agar. Blood agar e hemolysis ক প্রকার? তাড়াতাড়ি বলো। Hemolysis on the blood agar, how many types? তুমি হ্যাঁ, ব্লাড আগার দেখেছো তো? হ্যাঁ, ব্লাড আগারে কি দেখি আমরা? Hemolysis. How many types of hemolysis? তিনটে। কি কি বলে গেল? Alpha, beta, gamma. Alpha means what? Beta তো লেখাই আছে কেন? Beta means complete lysis. Alpha মানে কি? Partial lysis. Gamma মানে কি? হ্যাঁ? Beta lysis মানে complete lysis. Alpha lysis মানে partial lysis, as you have said. What is gamma lysis then? Hey, gamma lysis কি? See, if you don't understand what I am speaking, then you should ask. আমি একটা কিছু বলে যাচ্ছি আর তুমি কিছু বুঝলেই না, তাহলে কি লাভটা হলো? Gamma lysis means no lysis. Alpha মানে partial, beta মানে complete, and gamma lysis is a misnomer. Okay, gamma lysis মানে no lysis. ঠিক আছে, sit. আচ্ছা, so common infection যেগুলো করে, as you have said, কিছু soft tissue infection, skin infection, abscess, these are all the spectrum of Staph aureus. এছাড়াও আরো অনেক কিছু করে, we will come to it. Major importance it implicated in hospital acquired infection because there is one dreaded organism which is a Staph aureus, but which is a methicillin-resistant Staph aureus, or it is called MRSA. MRSA is a highly virulent or highly drug resistant Staph aureus which is difficult to treat. So we have to be aware and we have to be very conscious about MRSA. Now they have some virulence factors. Bacteria যদি highly virulent হয়, যে যত virulent তার তত virulence factor বেশি, কিংবা virulence factor এর mechanism গুলো শক্ত. So if you see, these are all the cell wall associated virulence factors. অনেক রকম virulence factor থাকে, কিছু toxin থাকে, কিছু cell wall এর components থাকে. So these are the components of the cell wall যেগুলো highlight করা রয়েছে. So what do we have? Peptidoglycan. Peptidoglycan is present in the gram-positive cell wall. That's because this is a gram-positive cocci cluster. They will have abundant amount of peptidoglycan in their cell wall. So peptidoglycan is basically a virulence factor because they give the rigidity to the cell. Rigidity to the cell এর জন্য কি হবে? They will be giving rise to the inflammatory response. ব্যাকটেরিয়াটা শরীরের মধ্যে ঢোকার পরে যে ইনফ্ল্যামেটরি রেসপন্সটা করবে, that is directly responsible by peptidoglycan. Also by teichoic acid. Teichoic acid এর জন্য the addition of the bacteria to the tissues, it increases. So the teichoic acid helps the bacteria in adhering to the mucosal surface. There is something called clumping factor or coagulase. Coagulase এই ব্যাকটেরিয়াটা দুই ধরনের রয়েছে, একটা bound coagulase, একটা free coagulase. Now what we are talking here in the cell wall, they have something called clumping factor. Clumping factor is also called as bound coagulase. Then we have adhesins. ঠিক আছে, দুটো অ্যাডেসিন রয়েছে, ফাইব্রোনেক্টিন বাইন্ডিং অ্যান্ড কোলাজেন বাইন্ডিং অ্যাডেসিন. দিস বেসিক্যালি হেল্পস দেম টু adhere to the surface of the host cell. Then we have something called as protein A. Protein A ki korche, they have anti-complement activity. So whatever your body is mounting a inflammatory response against the organism, they are having some proteins which has anti-complement activity. So they are basically evading your complement system. Then we have microcapsules. Whichever bacteria has a capsule, capsular function ki? Capsular function হচ্ছে they want to protect themselves from antibiotics. They want to protect themselves from different inflammatory cells of your body. So this bacteria has a microcapsule, hence they can inhibit the phagocytosis that is caused by the neutrophils. So these are the small things that helps the Staph aureus to evade or to invade the body. Now we have many toxins. As I told that Staphylococcus aureus is loaded with virulence factors. They have many toxins. Ki toxin ache dekho? Membrane active toxin. So they have alpha, beta, gamma and delta hemolysis. ঠিক আছে, এদের কাজ কি? They are responsible for destruction of RBC, for leukocyte destruction, and also they are responsible for necrosis of tissues. So whenever an organism has this kind of hemolysins, they will be definitely cytotoxic. So if these organisms are infecting a burned patient, it is very difficult to get them eradicated because of these kind of toxins which helps them to destroy the tissues. Then they have PVL toxin, that is leukocidin panton valentine toxin, which is basically having a synergistic action with the gamma hemolysin. ঠিক আছে, they also damage in a similar way the leukocytes, RBCs and macrophages. ঠিক আছে, তো এটা সিনার্জিতে কাজ করে with the hemolysin. Then they have something called exfoliative epidermolytic toxin. এটার কাজ কি? You see, this causes something called impetigo and exfoliation and bully formation. Okay, so basically this is responsible for the skin symptoms. ঠিক আছে, skin symptom কি হবে? They will have a Nikolsky sign. সেখানে কিনা if you press on to the the skin lesion, then you will have a separation of the superficial epidermis. You can feel that the lesion is separate from the superficial epidermis. That is what is the Nikolsky sign. So ekhane ki hoy, they have two toxins. One is ETA, which is a heat stable, and one is ETB or exfoliative toxin B, which is a heat labile. ঠিক আছে, so these basically toxins are responsible for staphylococcal scalded skin syndrome. It can come as a short note, staphylococcal scalded skin syndrome. তো সেখানে কি হচ্ছে, as you can see, bullous impetigo হবে, exfoliation of the skin হবে, সেখান থেকে রিটার্ড syndrome হতে পারে, এবং the child can also be affected with something called pemphigus neonatorum. ঠিক আছে, then you have something called enterotoxin. So you see the amount of toxins this organism has. So enterotoxin is basically concerned with all the symptoms of GI tract. GI tract এর symptom কি হতে পারে না, preformed যদি exotoxin থাকে, which is present in the food affected by Staph aureus. So there are many items like meat, dairy items, যেটা কিনা if you don't preserve it properly, হয় না যে একটা বাইরে থেকে একটা কোনো ডেয়ারি প্রোডাক্ট নিয়ে এলাম, বাট সেটাকে আমি রেফ্রিজারেট করলাম না, ভুলে গেলাম, গরমকালের মধ্যে automatically they will give rise to Staphylococcus aureus. And how the bacteria will affect, they will be releasing these toxins inside the food. So whenever you are having this kind of food, the symptoms will be occurring within 1 to 6 hours. খাবার খেলে 1 ঘন্টার মধ্যে you will have symptom. কি symptom? You will have emesis, that is vomiting and diarrhea. Vomiting is mostly predominant. তাহলে এত তাড়াতাড়ি তো একটা ব্যাকটেরিয়া গ্রো করতে পারবে না ইনসাইড ইউর বডি। So whatever is affecting your body is the toxin, and whenever an organism has a toxin which causes a disease, there is no antitoxin as such to prevent. There is no antibiotic which you can give because toxins are not killed by antibiotics. যতক্ষণ টক্সিনটা শরীরে থাকবে ততক্ষণ এফেক্ট হবে। ওকে, সো ইউ হ্যাভ টু ম্যানেজ দ্য পেশেন্ট কনজারভেটিভলি। ওআরএস দিতে হবে, আইভি স্যালাইন দিতে হবে, অ্যান্টিএমেটিক কিছু দিতে পারবে। But if you give a ceftriaxone to the toxin, it will not work because ceftriaxone is not directed against a toxin. You have to give antitoxin. ঠিক আছে, but antitoxin এসব ক্ষেত্রে দেওয়া যায় না। So they can cause a staphylococcal food poisoning type A, and they can cause a type F or a systemic reaction. Systemic reaction টা আরো ভয়ানক because they will be acting as a superantigens. Superantigen হিসেবে act করে they will be inducing a massive immune response responsible by the T cells. সেখান থেকে কিন্তু the patient may land up in toxic shock syndrome again. ঠিক আছে, তো this is basically দুটো পাথওয়ে দিয়ে হয়, মোস্টলি এই পাথওয়েটা দিয়ে থেমে যায়, but if the organism load is very very high, they can cause something like the superantigen mechanism which can give rise to a toxic shock syndrome. Toxic shock syndrome, all the shock features, feeble pulse, etc., will be present in the patient, and it is very difficult to revive those patients. Acha, this is the toxic shock syndrome as I was telling. এখানে কি হচ্ছে দেখো, there are two antigens or this is TSST1, toxic shock syndrome toxin 1, and TSST2, toxic shock syndrome toxin 2. এরা কি করছে, these are the super antigens as I was telling. So they are the risk factors are these things. যদি কোনো পেশেন্ট থাকে, বার্ন ইনজুরি আছে, যদি কোনো পেশেন্টের ওটি হয়েছে, কিংবা যদি কোনো পেশেন্টের অ্যাবসেস হয়েছে, কিংবা যদি কোনো পেশেন্টের অস্টিওমাইলাইটিস হয়েছে, কিংবা যদি if somebody is using this highly absorbent tampon for a long prolonged time, they are not changing the thing, so those things can give rise to a Staph aureus infection. সেই Staph aureus infection থেকে the toxic shock syndrome toxins can be released, which will act as a super antigen, and by acting as a super antigen they will be inducing a lot of APCs or T cells. সেখান থেকে they will be giving rise to cytokine storm. So whenever there is a cytokine storm in the body, immunology তে পড়েছো, there will be these three mechanisms. কি হবে, there will be hypotension because the fluids will be leaked out of the blood vessels, so the BP will fall, there will be hypotension, there will be diffuse rashes or desquamation or peeling off of the skin from the periphery, and there will be a multi-organ failure, so the patient will rapidly give rise to or go into a shock. So it is very difficult to revive these patients. So vomiting hobe, hypotension hobe, myalgia hobe, fever thakbe, all these things will come in and the patient will land up in a shock. So we have to manage it, hemodynamic stability tokhon manage korte hobe. Now these are the tests to diagnose the toxins. We don't have these tests in all the labs, only referral centers will have it. Like PCRs ache, latex agglutination ache, okay, enzyme immunoassay, ELISA gulo royeche. So any kind of shock the patient is, you have to aggressively manage the patient with fluids. Okay, so now coming to the virulence factor, virulence factor er moddhe kichu enzymes royeche. As I say, enzyme er moddhe I already told you the clumping factor, but this is the principal virulence factor or coagulase enzyme, which is a free coagulase. So free coagulase ki korche dekho, free coagulase of the Staph aureus যে এনজাইমটা রয়েছে, সেই এনজাইমটা will bind with the host prothrombin. prothrombin এর সাথে bind করে they will give rise to something called staphylothrombones. Staphylothrombones টা কি করবে, আমাদের বডির মধ্যে যে ফিব্রিনোজেন আছে সেই ফিব্রিনোজেনের সাথে অ্যাক্ট করে they will give rise to a fibrin, that is clot. These clots will be having these clots around them. So একটা cluster of Staph aureus, okay, producing coagulase will be binding with the prothrombin of our body. সেখান থেকে হলো staphylothromboin. Staphylothromboin will react with the fibrinogen. Fibrinogen থেকে fibrin তৈরি করলো, and that fibrin whole layer, it covers the organism all around 360 degree. তার জন্য কি হলো, they get blocked by phagocytes. Phagocyte বুঝতেই পারছে না ওটা Staph aureus রয়েছে, because it is blocked by fibrin. Hence they can multiply inside our cells, so they can evade the phagocytic mechanism. So if you don't give antibiotics, aste aste infection ta badbe, and the patient will land up into again toxic shock syndrome or sepsis or whatever. So that is the principal virulence factor. এছাড়াও they have staphylokinase, thermonuclease, DNase, hyaluronidase, অনেক কিছু রয়েছে. So these are all the enzymes. Okay, now coming to this infection, syndromes or symptoms. So already we have discussed, staphylococcal scalded skin syndrome. Now we will discuss the skin and soft tissue infection. Majority of the Staph aureus patients that will come to you in your entire medical career will be abscess and sepsis. Abscess কেন? As I told, these bacteria are responsible for most of the skin infection, including furuncle, folliculitis, carbuncle and abscess. এক একটা form. So abscess is basically a most, কি বলবো, advanced form of these things, যেখানে কিনা the patient may land up into a large abscess which you have to drain surgically. See, abscess is a structure or is a infection যেখানে কিনা there is less blood supply. So if a patient comes to you with suppose an abscess in the hand, ঠিক আছে, and you are continuously bombarding the patient with linezolid and this amoxicillin, clavulanic acid and everything, if the abscess is large, it is very difficult that the antibiotic will penetrate the abscess. It will not penetrate the abscess. So whenever you have an abscess which is drainable, it is recommended that you drain the abscess, because abscess যদি বড় হয় and if you are giving the antibiotic, you are harming the patient more, because সেই abscessটা কিন্তু will not be affected by the antibiotic. Penetration of antibiotic inside the abscess is very poor. So you have to surgically drain and then give the antibiotic. That is the recommendation. Okay, then you have cellulitis, which is common. Surgical site infection is very common. But one important thing and one, a good thing rather, I would say, that we don't have a majority of Staph aureus infection in our country, especially MRSAs. MRSA is not so much prevalent in India. It is prevalent in the Western hemisphere. So the western part of the world, they are more concerned or more tensed with MRSAs and all these things. We are tense with MDR GNBs, the multi-drug resistant Klebsiella, the multi-drug resistant Acinetobacter. MRSA আছে, but it is less in number if you compare it with the western population. Then you have mastitis, hidradenitis, all these things which are concerned with each part of the body, they are named differently. Then you have septic arthritis, osteomyelitis, abscess, as I told. Yes, ventilator associated pneumonia. They do cause VAP. Although it is not a very common cause, but they do cause VAP. They do cause CLABSI, central line associated bloodstream infection. They definitely cause surgical site infection. Okay, and sometimes they can also cause a catheter associated UTI. It is not common that a Staph aureus is causing a UTI. Rather, a VRE or the Enterococcus can cause a UTI, common than Staph aureus. But Staph aureus, especially MRSAs, they can cause Coccis. And ultimately, all these things will lead to the patient into a bacteremia if it is there in the blood. and ultimately it will cause a sepsis and a septic shock. Once a sepsis is established, the patient has long-standing a multi-organ failure. It is difficult to revive the patient. Repeatedly I am telling the same thing, because if you cannot diagnose early, if you cannot start the antibiotics early, what will happen is the organism will be there in the blood or will be there in some organs. So it will be, giving rise to multi-organ failure, and then the patient suddenly will end up into sepsis, you will never know. So it is very difficult. Yeah, this is already discussed. Sometimes you will see that we are also having Staph aureus on our skin, in our body, but it is not causing an infection. So kothay thake? They will be present in the anterior nares, oropharynx, skin, vagina, axilla, perineum. So all these parts of the body, they will be colonized with some Staphylococcus. It can be aureus, it can be Coagulase-Negative staph. Hence, it is recommended that whenever a patient is going in for a long bone surgery or for an implant surgery or for a cardiothoracic bypass grafting, okay, these are the cases where we do a screening of MRSA of the patient from these areas. We take a axillary swab, we take a nasal swab, we take a groin swab. So, এই জায়গাগুলো থেকে we have to screen whether the patient is having a MRSA or not. If we find that the patient has MRSA, we will give intranasal mupirocin, per-nasal mupirocin. Because if the patient has MRSA and you have operated on the patient, a long surgery, which is 5-6 hour surgery, the patient may develop SSI, the patient may develop osteomyelitis, the patient may develop implant infection. And once the implant is infected, you cannot do anything but remove the implant. It is very difficult. So, it is recommended that long surgery যেগুলো আছে, implant surgery, cardiothoracic surgery, সেখানে we generally screen these areas for colonization by MRSAs, Methicillin-Resistant Staph aureus. Now coming to the lab diagnosis, it is very simple. It depends on the infection site. You tell the infection site is an abscess located in the perineal region. So what do we send? Do we send a sputum? No. We send a swab culture, or rather we send a pus culture, aspirated pus. Aspirated pus is a more, better sample than a swab culture, because swab you are taking from the surface. A pus aspiration cannot be taken from the surface. It has to be aspirated from the abscess itself. Right. So, you send the samples according to the infection site. If you suspect the patient is having a device associated infection, suppose the patient is having a CLABSI, you will send one blood culture from the catheter, the central line, one blood culture from the peripheral site. So, whenever you are sending a blood culture for the patient, always send two. If the patient is not having any central line, send from left hand, right hand. Do not send from femoral lines or femoral site, because again the femoral sites are colonized with cons or other organisms. So, whenever sending a blood sample for culture, send two, aerobic, that is left hand, right hand. If you are sending to rule out catheter associated line infection, central line associated bloodstream infection, then you have to send one sample from the central line, another sample from a peripheral site. Central line যদি থাকে তাহলে central line থেকে একটা দিলে আরেকটা দিলে হয়তো left brachial থেকে কিংবা right brachial থেকে, whatever you want. Because if the central line is growing the organism and the peripheral side doesn't, that means central line is colonized with the organism. It has not yet come to the bloodstream. ওটা ওখানেই রয়েছে. Then you have to give antibiotic block therapy or remove the line. If the organism is isolated from both the peripheral and the central line, that means the organism is probably associated with the central line. In that case, you have to see the time difference. সেন্ট্রাল লাইন থেকে একটা ব্লাডকে আমি যদি নিই আর একটা পেরিফেরাল লাইন থেকে একটা ব্লাড নিলাম, দুটোকে আমি একই সময় ইনকিউবেটর দিয়ে দিলাম, পরের দিনকে the machine flags positive. The central line blood culture flagged 2 hours earlier than the peripheral site. That means the concentration of organism in the central line blood was more, right? In that case, we can take it as a CLABSI or CRBSI. This is called the differential time to positivity. মানে দুটো লাইনের মধ্যে, সেন্ট্রাল লাইন আর পেরিফেরাল সাইটের মধ্যে যদি 2 ঘন্টার টাইম ডিফারেন্স থাকে, and the central line will be flagging 2 hours earlier than the peripheral site, that means the organism load in the central line is high, hence it is a inclusion criteria for catheter, central line related bloodstream infection. বুঝেছো? So this is called DTTP or differential time to positivity. It is very, very important. If you see a report of the blood culture, central line আছে, peripheral line আছে, always see the time to detection, TTD টা লেখা থাকবে। TTD থেকে you have to calculate. সবাই কিন্তু ফোন করে বলবে না যে এটা সেন্ট্রাল লাইন আইসোলেটেড বিএসআই হচ্ছে, কাইন্ডলি রিমুভ দ্য লাইন। So whenever you are having a CLABSI and you are treating the patient with the central line present, it will never heal. You have to remove the line first. না, লিডাসটাকে রেখে দিয়ে অ্যান্টিবায়োটিক দিয়ে কি হয়? You have to remove the line and then give the antibiotic. That is the rule. So they will be cultured into nutrient agar, blood agar, McConkey agar. Nutrient agar, as I said, there will be golden yellow pigmented colonies. Blood agar, there will be beta lysis. You see, complete lysis around the colonies, beta hemolysis. And then in the McConkey agar, it will be lactose fermented or LF colonies. So these bacteria, they do ferment lactose. Hence, they'll give rise to lactose fermenting or pink colored colony. Okay. And then you can do, further testing. You can do antibiotic sensitivity testing on the Mueller-Hinton agar, or you can put the organism for the automated sensitivity for Vitek or microscan, whatever you have. So these are the things that can be done. Yeah, few samples which is not required for culture of Staph aureus, যেখানে কিনা they can be present as a commensal flora. কিছু স্যাম্পল আছে like fecal matters and these things. So এখানে কিন্তু Staph aureus can be a commensal. So isolation of those organisms from these samples are not always conclusive. So it can be given as normal flora. Biochemical testing, I have already discussed catalase-positive, coagulase-positive. Coagulase এর মধ্যে দুটো মেথড আছে, you will learn in the practicals again. Coagulase এর মধ্যে first is a tube coagulase which requires 4 hours of incubation at 37 degree. So you take normal saline, you take plasma of the patient, সেখান থেকে you mix it in a ratio and then you put a colony in the solution and in a slanting state you put it for 4 hours incubation. Incubation এর পরে if you tilt the tube back, you will see the whole tube has gelled, একটা জেলির মতো হয়ে গেছে. So that is coagulase-positive. On the contrary, if you see slide coagulase, সেখানে কিনা Staphylococcus aureus এর কলোনির সাথে you directly give the plasma. যদি প্লাজমাটার সাথে রিয়াকশন থাকে, if the slide coagulase is positive, then you will see that coagulum formation is there inside the on the slide. You can see it very clearly. Clump formation হয়ে যাবে. So this is basically the clump formation. এটাকে আমরা coagulum বলবো না, we call it clumps, and this is basically we call it coagulum. ঠিক আছে? So this এটা কিন্তু bound coagulase represent করে, and this will be representing the free coagulase. Antibiotic sensitivity, already I have told that rapid antibiotic sensitivity করা যায় in various machines like Vitek and all these things, but then you can also have manual disc diffusion method with normal antibiotic discs. But একটাই জিনিস যেটা কিনা very important in this kind of organism is drug resistance. Drug resistance এর মধ্যে যেটা main drug resistance সেটা হচ্ছে MRSA. You see this methicillin resistance, where is it? So this is the MRSA, which is very common. 30% of the Staph aureus are MRSAs, and VRSA we call it vancomycin resistant Staph aureus. VRSA কিন্তু আরো কম, মানে MRSA যত বেশি VRSA is very less. There is something called visa. It is not that passport visa. It is visa means vancomycin intermediate Staph aureus. প্রত্যেকটা অ্যান্টিবায়োটিকের একটা MIC কাট অফ ভ্যালু আছে, মিনিমাম ইনহিবিটরি কনসেন্ট্রেশন কাট অফ। দ্যাট মিনস এই কনসেন্ট্রেশনের তলায় যদি অ্যান্টিবায়োটিকটা যায় দেন ইট ইজ সেন্সিটিভ। সো ভ্যাঙ্কোমাইসিন ইজ লেস দ্যান 1 যদি থাকে দেন ইট ইজ সেন্সিটিভ। We are not bothered with VSSA. We are not bothered. Keep it outside. We are bothered with whenever the MIC is greater than 1, then we can call it a visa. যদি MIC 16 বেশি হয় তাহলে তো VRSA হয়ে গেল, vancomycin will not work. In case the MIC is greater than 1 and falls below 16, that is 4 to 8 or 2 to 8, whatever, then we call it visa. In case the visa strain is detected, you should not treat the patient with vancomycin. You should take other options like ticoplanin or linezolid or whatever it is. Now the drug of choice for VRSA is basically linezolid, and the drug of choice of MRSA is basically vancomycin. The drug of choice of methicillin sensitive Staph aureus is cephalosporin. You can give ceftriaxone, you can give cefuroxime or whatever you want to give, but once you detect a MRSA, methicillin resistant Staph aureus, you should not give a cephalosporin. You should not give a cephalosporin. But there is one exception. There is one cephalosporin which can be given to a MRSA. You find it out, what is it, and you tell me in the next class. Right. Name the cephalosporin which can be given in a MRSA. Very specific. Name the cephalosporin antibiotic which can be given to a MRSA. Okay? Find it out yourself and let me know. So the drug of choice for MSSA or methicillin sensitive Staph aureus is a cephalosporin. The drug of choice of MRSA is vancomycin. The drug of choice of VRSA is generally linezolid, but linezolid is again a drug which requires a lot of monitoring to the patient. Thrombocytopenia hoy aro onek kichu hoy linezolid theke, so you have to put the patient under monitor. Okay, so VRSA drug of choice linezolid. Alternatively, you can also give telavancin, daptomycin. Okay, so these are the alternatives that you can give to the patient. Now control measures. How we can control a MRSA? MRSA is very difficult. If you have a MRSA in your hospital and if you don't have a good infection control, then you are in trouble. The MRSA will spread from one patient to another patient and you will start losing patients. Okay, so screening of MRSA is very important. As I told, you can take nasal swabs and you can screen for MRSAs of the staff, of the patients. Then you have to decolonize the carriers. If you find out that MRSA is being carried by staff or patient, then you have to decolonize. OT age you have to give the patient 2% mupirocin ointment per nasal. Then you have to give chlorhexidine body wash, cano, to decolonize the patient from MRSA, so that the patient may not land up into SSI. That is very important. If you don't decolonize before a cardiothoracic surgery, it is very difficult. You can have a SSI. CTVS SSI hole khub mushkil ache. They have a long cut that is there in the thoracic cage. Then if MRSA is found, generally we put the patient into contact isolation. If you have MRSA on the skin abscess, we generally put the patient into contact isolation in a single room so that it doesn't spread to the next bed. Then you have the best method, which is hand hygiene. which is the most important thing, কেউ করে না সাধারণত, যতক্ষণ না পিছনে লেগে থাকা যায়, nobody will do it, everybody will forget, especially before touching a patient. After touching a patient they will do, because after touching a patient they have to touch their mobile, they will do hand hygiene. Before touching a patient nobody will do. আমার তো পকেট থেকে হাত বার করেছি, পকেট তো স্টেরাইল. Who told you your pocket is sterile, man? Your pocket is the most unsterile thing in the world. So you have to do hand hygiene in all the 5 moments. Kiki moment bolo to? Before touching a patient, after touching a patient, before performing any sterile procedure. No, wrong. Next, before touching, after touching and before doing a sterile procedure hoyeche, তিনটে hoyeche. তারপরে after touching a patient's environment. Okay, I agree. Anything else? 5টা আছে, 4টে আছে. Next, parallel. 4টে হয়েছে. Before touching a patient, after touching a patient, after touching patient surroundings, before doing any aseptic procedures. What is the 5th one? Iki, Passajon? The nursing people can tell it fluently. Tell. What is the 5th one? Hand hygiene moments. If you don't know the hand hygiene moments, what will you teach in the hospital? তোমাকে তো ওয়ার্ডে জিজ্ঞেস করবে নার্সিং স্টাফ, ম্যাডাম দেখুন তো মোমেন্টসটা ঠিক আছে কিনা. You will be assessed by ICN. You will be seen, when you are going into rounds. What is the 5th one? Nobody knows hand hygiene moments. Huh? What is it? Jano na? Passajon? Anybody knows which is the 5th one? Gemini, ChatGPT. After body fluid exposure, they have done Gemini already. কি করলে তুই পিছনে বসে? এখান থেকে কোয়েশ্চেন শুরু হচ্ছে, ওখানে বন্ধু ChatGPT হয়ে যাওয়ার কথা ছিল. সি ইন্টারনেট কানেকশন নেই তোমার, হবে না. Sit down. After a body fluid exposure, hand hygiene moments should be on the tip of the tongue, and the process of hand rub or hand hygiene, the steps of hand hygiene rather. These are the things that you cannot forget, because people will ask you, you will be teaching to the staff. তুমি নিজেই জানো না তোর তুমি স্টুডেন্টকে টিচ করবে, তাই নয় কি? This is very embarrassing. So don't do it. Coagulase-negative staph, I will not take much time. Already I have told these are all concentrated in the various areas. Actually, few coagulase-negative staph, they do cause virulent infection to the patients. তার মধ্যে we have something called honeymoon cystitis, which is very common in the young sexually active females, and then they basically can cause biofilm formation on catheters. So whenever you are having a catheter on the patient, you have to be beware of this Staphylococcus saprophyticus, because they do cause biofilm on the catheter and they do cause Cocci. Okay, so cons isolation elomane we don't treat. No, in case the patient is having a catheter, you have to be very aware. In case the patient is having a central line, you have to be very aware of this kind of coagulase-negative staph. And they do cause osteomyelitis. My thesis in MD was osteomyelitis, and definitely I have found out that Staphylococcus lugdunensis, which is very less, it is isolated from the clinical samples. Staphylococcus lugdunensis, they cause osteomyelitis. It was a very good finding that was present in my thesis. And they do have many kind of virulence factors like lipase and clumping factor and all these things. They can cause infections. I think that's it.